Good afternoon, all. So, first of all, I want to thank the IHPBA Scientific Committee and Organizing Committee, Dr. Sanjay, for inviting me here. So, I will be talking on venous thrombosis in acute pancreatitis. As we all know, the vascular complications in acute pancreatitis are not very uncommon, but especially the venous complication is a very less studied complication in the literature. And the major guidelines are silent on this aspect, but the incidences of venous complications, especially splanchnic venous thrombosis, ranges from 15 to 20%. So, how the venous thrombosis develop in acute pancreatitis? The first is due to inflammation. There is a direct insult on the endothelium which can result in venous thrombosis. There are inflammatory mediators, interleukin 6, TNF alpha, which activates and results in the venous thrombosis. And due to the pancreatic necrotic tissue, there is a activation of the coagulation cascade that can cause the venous thrombosis, and the compression of the vessels directly by the collection or necrosis can result in the venous thrombosis. So, what are the factors which are responsible or risk factor for splanchnic venous thrombosis? The one very clear thing is that if it is directly proportional to the severity of the pancreatitis, and in those patients there is a local complication in the form of collection or necrosis or word of pancreatic necrosis, the chance of SVT is high. The other factor in the literature which shows the association is the male gender, alcohol etiology, and the sepsis or bacteremia. So there are few studies which try to predict the severity risk factor for the splanchnic vein thrombosis. The patient who are younger has a higher risk of having thrombosis. The patient who had a high CRP levels or in which the CIRS score is high, in there the chance of having thrombosis is high. The pattern of necrosis is important. The patient who had a left-sided central or subtotal necrosis, the chance of venous thrombosis is high. This is another study which showed that if the Ranson score or organ failure is there, then the chance of having thrombosis has increased. The patient who had a local complication in the form of necrosis or collection, the risk of thrombosis is high. And those patients who had a thrombosis, they land up with the ICU stay, more ICU stay and the hospital stay. Another study in which the multivariate analysis was done, in which it has been seen that the patient with the alcohol etiology or higher necrosis extent has an increased risk of thrombosis. If you'll see the pattern of involvement, the most common vessel involved in thrombosis is the splenic vein, which is 10 to 14%. The second most common is the portal vein, followed by SMV, and the combination of these veins thrombosis can occur in 5 to 38% of the patients. This is the one study in which they evaluated 256 patients, and out of 256 patients, in 35 they found venous thrombosis or venous narrowing due to the collection. And what they found is 22 patient had a thrombosis, and the pattern of involvement was 15 patient had a single vessel involvement, and the splenic vein is the most common vein which get involved in the thrombosis. So this is a study in which, a recent study in which they try to see the pattern of parenchymal necrosis per affected vessels. So in patient in which there was a left-sided necrosis, the most common vein involved was the splenic vein, followed by the superior mesenteric vein. If the necrosis is central, then the distribution of necrosis is almost equal among the three vessels. In right-sided, the superior mesenteric vein was most commonly involved, followed by the portal vein, and subtotal it was equal. And once this thrombosis develops in after acute pancreatitis, what is the presentation? One is the acute presentation when there is acute thrombosis of vessels. So acute thrombosis can result in abdominal pain, GI bleed, nausea, or it may be asymptomatic in 17% of the patient. The second presentation may be a sequelae of the thrombosis in the form of portal hypertension, in which you can see the left-sided portal hypertension. You can have a gastric varices, or there can be a chance of bleeding from the gastric varices, which is usually small, ranges is around 6%, and splenomegaly can be seen in around 50% of the patient. So how to investigate this patient? The first line of diagnosis is a color Doppler, is a non-invasive, cost-effective, easily available, but the limitation and acute pancreatitis it is very much operator dependent, and due to the disease there is a poor acoustic windows for assessment of these vessels, and anatomical detail is very difficult to delineate in the presence of acute pancreatitis. So what we usually do in this group of patients is a contrast enhanced CT, where you can assess the severity of the disease, you can clearly see the vascular structure, you can delineate the anatomy, and more important is you can see the evidence of bowel ischemia in the form of bowel thickening or pneumatosis. The another armamentarium in the hand of the medical gastroenterologist is the endoscopic ultrasound, where they can that can help in diagnosis the venous thrombosis, and at the same time, if indicated, they can do the some therapeutic intervention if there is some pseudocyst or word of pancreatic necrosis. So how to treat this disease? First and foremost important is not to treat the vascular thrombosis, is to treat the underlying pancreatitis depending upon the indication and the severity. The second is the management of the splanchnic venous thrombosis, and third is the management of the sequelae of the venous thrombosis. So there are many unanswered questions when it develops in acute pancreatitis. What is the evolution of this thrombosis? Whether they have occur progression or there is some resolution. What is the impact of venous thrombosis on the clinical outcome or role of anticoagulation? We'll try to see what literature says about these questions. So this is one study in which a last study of 335 patients compared the 335 patients with no thrombosis with the 97 patients who had a thrombosis, and what they found is that the diagnosis of SVT is within the 4 days of the admissions, and it was diagnosed in the first CT in around 78% of the patient, and in second CT in the 18% of the patient, and 4% had in third CT. So probably from this study, it is very clear that venous thrombosis usually occur in the early phase of the acute severe pancreatitis. How it evolves? In the same study, they followed this patient, and what they found is that around 57% of the patient, they develop recanalization of these vessels. And the time of recanalization is 4 weeks. So majority of the patient, the vessel get recanalized. And if we'll see the outcome of the patient who develop thrombosis vis-a-vis no thrombosis, the death rate is similar between the two groups. Organ failure is more common in patient who had a thrombosis. Bleeding risk is high in patient who had a thrombosis. Bowel ischemia is high, 4% versus 0.06%. ICU admission is more in patient who had a thrombosis compared to no thrombosis. So the most common pattern is a isolated splenic vein thrombosis. Here you can see if the splenic vein thrombosis is there, the pattern is that there was a formation of the gastric varices. So this is a paper which tried to sort out the natural history of 800 natural history of the splenic vein thrombosis. It occurs in 22% of the patients. Splenomegaly was noted in 50 and varices in 53%, and GI bleed occur in 12% of the patients. So usually the splenic vein thrombosis has a benign course. So the next question is when and how to start the anticoagulation. So there is no consensus, there is no guideline on the use of anticoagulation, and data on the risk and benefit of the anticoagulation is still very limited. If you see this study, this study compared the patient who had anticoagulation with no anticoagulation. What they found is the recanalization rate is similar between the two groups. Time to recanalization is same. There is no increased bleeding risk between the two groups, and bowel ischemia is same. This is another meta-analysis of 16 study of 698 patients, where what they found is that the recanalization is higher in patient who had anticoagulation. The risk of bleeding is similar between the two groups. The mortality is similar between the two groups. And what they found is that in two groups, there is no significant difference in the intestinal ischemia, portal cavernoma. So there are conflicting studies in which it is not very clear the anticoagulation helps or not. Risk of bleeding, hemorrhage in anticoagulation, the data is still heterogeneous, but logically there is an increased risk of bleeding in patient who had a splenic vein thrombosis, because SVT develops usually in the higher risk patients, the moderate to severe pancreatitis with local complication. And the necrotic collection inflammatory injury to blood vessels results can have an increased risk of bleeding. And when you do therapeutic intervention in this group of patients, and especially they are on anticoagulation, there is always an increased risk of bleeding. So this is another study in which they compared the anticoagulation with no anticoagulation, and what they found is the resolution of thrombus is similar between the two groups. There is collateral formation is similar, mortality is similar, but the bleeding is high in patient who had a anticoagulation. So then a group come with another study in which they use the selective anticoagulation. Selective anticoagulation means they use the anticoagulation. It's a retrospective study. So I will take 1 minute. Thank you. So selective anticoagulation means they did an anticoagulation in patient who had a SMV or portal vein thrombosis, or in those patients who has a progressive thrombosis in the splenic vein. So 67% of the patient received anticoagulation. The anticoagulation used was anaxoparin and apexamin. And what they found is the bleeding risk is not very significant between the two groups. The recanalization was very significantly higher in patient who had a portal vein and the splenic vein, SMV thrombosis as compared to the splenic vein thrombosis. Mortality in patient who had a splanchnic vein thrombosis or in patient in which the coagulation and anticoagulation was used is not significantly different. So a selective anticoagulation policy for the portal vein thrombosis or progressive splenic vein thrombosis is associated with favorable outcome with no increase in bleeding. It was the gist of this publication. So does the venous thrombosis, there is an implication of venous thrombosis in pancreatitis management? Yes, there is. The severity of the AP is governed by the development of the thrombosis. The more severe disease, the local complication is high, the necrosis is high, which often require intervention and the surgery. And the risk of bleeding is highest in the presence of the thrombosis. The more frequent intervention is required if the patient is on the anticoagulation, and if we are doing the more number of intervention and patient is on the anticoagulation, you have to stop this anticoagulation, and if you are stopping that anticoagulation, there is a poor recanalization. The risk of having the poor recanalization is there. The presence of collateral and splenomegaly can hamper your interventions. So with this, I conclude the venous thrombosis complication is not uncommon in acute pancreatitis. The risk increases with the severity of the disease. High index of clinical suspicion and is required for the diagnosis. Isolated splenic vein thrombosis can be managed conservatively, but in portal vein thrombosis and SMV thrombosis or extension of the splenic vein thrombosis can be considered for the therapeutic anticoagulation. Still, the data is very limited. SVT hinders the management of AT and can adversely affect its outcome. A large multicentric collaborative efforts are required to better understand this common problem, this understudied complication of the acute pancreatitis. Thank you.
Thank you. Any questions from the floor?
Sir.
Yeah, very well presented. I just wanted to ask is, cannot we, because anticoagulation especially, we saw most of them recanalization in 4 weeks, and splenic vein thrombosis and portal vein thrombosis are predictors which says that this is going to be a necrotizing pancreatitis where we are going to require intervention. Then why do we really need anticoagulant? Because the newer drugs probably are pushing through, so I guess probably it's safer not to anticoagulate.
Yes, I agree. That's why I think literature is very limited. But I think the only question is, we cannot have a very clear-cut guideline. So there is a clear answer. If it's a splenic vein thrombosis, no intervention. But suppose the thrombus is extensive, portal vein is involved, especially the lower splenic vein, the SMV is involved in the whole length. So in those group of patients, I'm not sure, there is no literature, but if we are not intervening, there is no indication of any surgery at that time or intervention at that time, I think these patients might get benefited from anticoagulation. But still, I think there is no clear-cut data. I agree.
Sir?
I wanted to ask 2 questions, sir. My first question is that in patients who have portal cavernoma formation as a complication of venous thrombosis and recurrent acute pancreatitis, and they go on to develop symptomatic portal biliopathy, do you change your strategy and not do a two-stage procedure? That is first a PSRS and then subsequently hepaticojejunostomy, and do you do an upfront HepJ owing to the difficulty that you feel that these patients may have because of the severe fibrosis and scarring and the retroperitoneum?
So I think very difficult question means if the patient is having portal cavernoma over and above, there is a acute necrotizing pancreatitis, and doing any shunt surgery in this patient is I think really difficult. So I'm not sure whether surgery will help in this group of patient or not. Or doing HJ in this group of patient is, I think, is always an individual approach based on the collateral, how much collaterals are there, whether you want to take that risk or not. So I think it has to be individualized, but I think there is no clear-cut answer to this.
And sir, do you personally give anticoagulation for patients?
We don't give. We never gave, I think.
Yes.
Sir, it was a nice presentation. I know, Vijay, you have the highest volume. I just want to ask you, since data are very heterogeneous, in acute setting with portal vein thrombosis in collections, sir, when you decide to operate?
When to decide to operate?
To operate for vascular, it's like only portal vein thrombosis.
So surgery for the necrotizing pancreatitis, not for the...
Yeah. Necrotic pancreatitis, you have dealt with like pictal, all done, but in clinical.
So I think the indication of necrosectomy or intervention will remain the same. The only thing is that you have to be more careful. The surgeon will be little afraid in doing surgery in those. You should be ready for the bleeding and to tackle that bleeding, and maybe sometimes a lot of collaterals, you should be ready for the packing and all these things. But I think indication usually remains the same, but maybe if you have to choose between the surgery, necrosectomy vis-a-vis minimal invasive or pictal drainage or some percutaneous drainage, I think if both options are okay with that patient, we'll go with the minimal invasive or percutaneous methods.
Sir, mainly because of portal vein thrombosis, you are suspecting bowel ischemia. It is mainly because of both thrombosis. Unless and until there is arterial component, usually it is very straightforward. But in portal vein thrombosis, is it that some patients land up in surgery because of bowel ischemia? Or sometimes pneumatosis is there. Is it really?
The incidence is very less. If you'll see the literature also, the incidence is 4 to 5%. So I don't think so there is a very high incidence, but if there is a clinical suspicion, then you have to go in and then...
I would just like to add one thing, that in our armamentarium, there are endovascular interventions also. You need not to operate on those patients who are high risk. Maybe it can be managed by endovascular techniques also.
Still, endovascular thrombolysis can be attempted if, yes, I agree with Saket.
Anticoagulation, if you have to give, actually which anticoagulation you give and follow up?
I think if the literature says it should be a low molecular weight heparin, enoxaparin is okay. But there are few studies in which they give a conventional heparin because it's easy to titrate, and but in most of the literature, if you will see, they have given the low molecular weight heparin.
On discharge, do you give on oral?
We have never given, no personal experience, but literature says the one study used the apexaban.
All right. Thank you.